Okay, this is session D68, lower extremity issues number 2, clinical case side selection. My name is Tom Best from Ohio State. I'll be the moderator, and my 2 case discussants this afternoon. To the far left is Pierre Vivier from Stellenbosch University in South Africa. Welcome, Pierre. And then to his right is William Mann from the Naval Health Center, Naval Health Clinic in New England. So I think most of you have been involved with these cases before. I know as program chair during my president-elect year, it was a lot of fun to put these together. We really enjoyed doing this, and we want to make this an informal session as much as possible. The only thing that I ask is that you try to be collegial. I've been in some of these that are not so collegial, and I think that is really unfortunate. It's not good for any of us to be that way. I guess the bottom line is if you weren't there at the time of the case, it's easy to play Monday morning quarterback, and I've certainly done that to people, and that's not good. So let's not do that, okay? This is meant to be informative, educational for all of us. That's medicine, as we all know. Okay, our third case this afternoon, titled Thigh Compartment Syndrome in a Factor VII Deficient High School Football Player, will be presented by Dr. Jeremy Burnham.
I'm an orthopedic resident at University of Kentucky with Dr. Ireland. I want to really just thank the American College of Sports Medicine for kind of giving us this venue where we can have these multidisciplinary discussions, and I think it's pretty unique and definitely valuable. I want to thank my co-authors and especially Dr. Ireland, who's here in the audience. This is a program from a 1998 ACSM conference where she was actually imparting sports medicine knowledge on my dad, who's a primary care sports medicine doctor. And to follow that up, in 2009, I met Dr. Ireland at an ACSM conference, and she's a large part of the reason that I came to train at Kentucky. And she gave a talk on uncommon presentations of common conditions and when things don't appear like what they really are. I think that's fitting for what we're doing. So she's continued that. She puts on a skills lab with our residents, and she's certainly an exceptional teacher. So I just want to thank her. And so we'll get started with the case. The chief complaint is thigh pain. This is a 16-year-old high school football player who came to us, and he had 3 days of thigh pain and swelling that just kept getting worse. So talking to him a little bit, he had actually had a direct blow to his thigh about a week before he came and saw us 7 or 8 days in a football practice. And he said he had some pain and some swelling at the time, and it really got better pretty quickly. And he actually went back to practicing football and played in a game on Friday night, didn't have any problems. But the next morning, so Saturday morning after his game, he woke up and he noticed that it was hurting him again. It was starting to swell. It continued to get worse over 3 days. He went to an outside emergency room. They got some x-rays, and they told him, well, we think you just have a contusion, so it should get better with time. Well, it didn't. It kept worsening, and ultimately he found his way to us. And when we saw him, he really couldn't walk because the pain was that bad. On exam, he had visible swelling. His thigh was pretty large. It was definitely tense with palpation, and his knee range of motion was significantly limited, and that was kind of a red flag right there. He really didn't have much quad strength. He could fire his quad a little bit, but he had no active motor. But distally, he was intact. And he said he had a little decreased sensation over his anterior medial thigh. It wasn't that impressive. He could tell that we were touching him. But most noticeably, he just had a lot of pain with any kind of passive stretch or especially flexion of his knee. Pulses were symmetric. They're palpable. He had good perfusion to his foot, so it didn't seem like anything vascular was really going on. We got some basic lab values. His hemogram was significant only for just a slightly increased white blood cell count, but his H&H were fine. Coags, his PT was a little bit elevated, and he had an INR of 1.6, which we kind of thought was interesting, but didn't know what to make of it. PTT was almost normal, a little bit on the high end of normal, though. So we got some x-rays when he came in, looking very closely, did not see any type of fracture or acute injury. You can see the swelling. You can appreciate the swelling in his thigh on that lateral x-ray and that soft tissue profile. So we got some cross-sectional imaging, which I've labeled here just to make it a little more legible. You can see that all of this muscles there in the anterior compartment and what looks to be a hematoma. The CT did not have contrast, and it was kind of difficult actually to tell what it was here. And actually it was a CT from an outside hospital, one of the other ERs he went to, and did not go all the way up his thigh. So we weren't real sure what to make of that.
So I'll jump in and ask a couple questions. So you mentioned he took one hit and then he went back to practice play or whatever. And it's not, did he take a second hit? Do we know, or he just was having difficulty from that?
He says he had no other problems. It was the initial hit. It was one of his co-teammates' knee hit his thigh, and he had some pain, came out for a few plays. Actually didn't really do much the rest of the practice. But then went back in and said that in this game and the other practice he went back into, he didn't have any issues. So.
And then second question, we all know how accurate adolescents are in reporting symptoms and history, but any NSAIDs he was taking?
Right, so he was not on any medications, and I didn't put it up there. He had a stone-cold, normal past medical history, had never taken any medications, been in the hospital for anything, family was healthy, and went through that pretty thoroughly. And like you said, you never know how much to trust a teenager, but his mom was there, and she agreed.
Did you check his CK?
We did not.
Okay. And renal function, things like that?
Yeah, so his BMP was normal. His creatinine was 9.98, I believe.
Okay.
So.
Yeah, you may get into this on your next slides, but the choice of imaging going to the CT first, did you consider ultrasound or MRI on this guy?
You know, I think that the imaging was less than ideal. I think the X-rays, are always a good bet first. The CT was done at an outside ER, and I don't think it would have been our first choice, but it's kind of what we had. And his symptoms were, as he was admitted to the hospital, were progressively worsening, so then we did have to make a decision about, do we need additional imaging? Is it worth the wait, or do we know what's going on? So,
okay.
All right. Thoughts from the audience? Comments? Questions? Okay.
Okay. So our differential, one of the first things is a simple contusion, which definitely fits the history, and I think that's what most people thought he had. Thigh hematoma, we had a high suspicion for some type of hematoma based on that partial CT scan we had. Quad muscle strain, possibly. ACL injury, maybe it was kind of an abnormal presentation of an ACL injury. He had a knee effusion that was causing some swelling in his thigh, too. It's something to think about. Femur fracture, we felt pretty good between the plain films and the CT scan that there wasn't anything we were missing there. And then less common would be a delayed onset of compartment syndrome, but it's something we had to think about, and that's ultimately we made that diagnosis based on his exam and the fact that he continued to worsen. So treatment-wise, really the only thing for compartment syndrome is to decompress it. So we did a decompressive fasciotomy. Here's an intraoperative picture. So that's the lateral side of his thigh. What we did is split his IT band there, and the muscle that you're looking at is the vastus lateralis. So immediately when we got through the IT band, this muscle all came bulging out. It's fairly impressive. It was viable muscle, and we were able to move that muscle out of the way and see his rectus and the medius intermedius and see that everything was viable and healthy, but it was definitely under a lot of pressure. We did not, so we just did an isolated decompression of his anterior compartment. We didn't get into his posterior or medial compartments. We were able to feel around there and palpate them, and we didn't have much concern about that. So we just went with the anterior compartment decompression. We left his wound open, actually. We put a wound vac on it for 3 days, and then came back to the OR 3 days later and closed it. We did leave the IT band open so that his compartment stayed decompressed, but we were able to get the skin closed 3 days later. So it's been reported a few times before. Dr. Ireland reported on it in 1992. It's definitely, thigh compartment syndrome is not as common as some of the other compartment syndromes. She had a similar patient, a 17-year-old male football player. Exam was very similar, except that he presented at 24 hours, which is probably a little more common to present at that time frame rather than 7 or 8 days later. But decreased knee flexion and some decreased sensation as well. They concluded that anybody that has a direct blow to the anterior thigh with that kind of swelling and pain should really be considered for a compartment syndrome because it's difficult to detect. These are things that we all know. It's really one of the only true orthopedic emergencies. The 6 Ps we classically talk about, but I think that pain is the main thing we look at. Pain out of proportion in the exam and pain with passive stretch are probably the keys there. The other ones, if you have paralysis or pulselessness, the ship has really sailed at that point, so you want to catch it earlier than that. You can make your diagnosis, as we did, based from the history. Was there any crush injury, high-speed car accident? On the physical exam, although I think the physical exam is not 100% sensitive to catch this. And then you can measure compartment syndromes. It's a little bit debatable. Some people say an absolute value of 30 to 45. Some people say if it's within 30 of the diastolic. There's different things you can measure compartment pressures with. Here's a simulator that we use our first year of training to kind of learn how to get around the compartments. We did not test his compartment pressures due to his clinical exam being so positive and the fact that his symptoms were worsening. We didn't feel like it was necessary. But if you have a question, you can certainly take the pressures and give you a little more information. What's also a little more difficult about a thigh compartment syndrome is that we're used to testing the neurovascular status distally in the foot, and it really wasn't affected in this guy. And I think that's why it got missed for a while. For one reason, it was delayed, and the other reason is that really the femoral nerve was the only thing affected, and the saphenous nerve, which branches off of there. So his foot function was fine. And I think that people examined his foot and examined his calf distally and thought he was fine, and they didn't really know what was going on there. Just kind of little basis, there's systematic reviews on this. This was a good one in 2010 by Dr. Roberts, who's actually down the street in Louisville. A lot of them are from car accidents or motorcycle accidents, so it's usually high energy, and half of them have femur fractures, which this kid did not. But 20% had coagulation deficiencies, which is noticeable and kind of brings us to the next part of our workup. So we did preoperatively talk to the pediatric surgery team that had admitted him initially and talked about doing a coagulation workup based on the elevated INR. They didn't feel it was necessary, but due to the amount of oozing that we saw in the operating room, we went ahead and called Peds HEMOC later. They did a coagulation workup. Von Willebrand's factor was normal, platelet function was normal, and factors 9 and 8, which are a little more common deficiencies, were normal as well. But his INR was still elevated at 1.6, and then his clot time was slightly elevated. So his factor 7 was 15%, which is substantially low. This is, I'm sure everybody has the clotting cascade memorized, but I just put it up there for my own reminder. That basically factor 7, it's an important part of the extrinsic pathway and important part to forming a clot. So the fact that his is not at normal levels is causing him some issues. And in the realm of bleeding disorders, it's not very common. It's pretty rare. So I think that's one thing that kind of made it unique, but something to think about. So as you can see, the treatment is FFP and factor 7 replacement, and that's exactly what he got while he was in the hospital for about a week, and then continues to get it as necessary at home. So we saw him at 6 months. He was walking normal. He had good quad strength, a little bit deficient and atrophied compared to the other side, but otherwise 5 out of 5 motor, good normal sensation, not having any pain, wants to go back to playing football his senior year. So just to kind of summarize, I think that paragraph is good, that you really have to have a high index of suspicion when you have somebody come in and things aren't making sense, because this is kind of an uncommon presentation, but if missed, could be pretty serious. So, and I think the question is, what do you tell them returning to sports?
Okay, great case. Comments, questions, and maybe we can spend a couple minutes talking about return to sport, of course, contact sport. But maybe before we get to that, any other questions or comments and for either of our two surgical colleagues here and how they approach this?
How big was the hematoma at the time of surgery?
Yeah, it was.
Or was it more with the space occupied?
Yeah, I think that was a small part of it, but it wasn't as impressive as what you would think. We didn't have a bunch of blood come gushing out of there. I really think that the compartment pressures were high, and there was some necrosis going on, and those muscles were just bulging and screaming. So.
Just a comment, and I think we've referred to the early use of the MRI.
Yeah.
So that could have put you quite quick on the diagnosis. Also,
Yeah.
if there's changes in the muscle signal. But the other thing also is, I think in retrospect, you made a very good decision not to stick a needle in there.
Yeah.
So
Right.
to do the compartment pressures. So that's just 2 comments.
Yeah, I think I think it's a good example of it's such an uncommon presentation or problem that he saw many healthcare providers that kind of missed him, and he, like you said, he got a CT scan a day or 2 before that wasn't really that helpful, and either better imaging or just recognizing what was going on earlier, I think would have been more appropriate. So.
Yeah, and I think the other thing is also what they say, the misdiagnosis or the improper diagnosis is and that's you started with the X-rays, is when you don't see the the fracture, you think it's just a contusion. And I think that's the other important point, that your suspicion was high enough to work that. I was just thinking, in my own clinical practice, working with rugby players and see these on a daily basis, how many I missed.
Right.
That's.
I know.
The one comment I would have, on the initial laboratory test, you called hemoglobin hematocrit normal, and I would argue from a surgeon standpoint that's safe, that's normal at 37. But for an adolescent male going through puberty, you'd really expect his hematocrit to be somewhere around 45 with all the testosterone flowing around. Yeah. So I think that was definitely an indicator that he's losing blood somewhere.
Right.
So another little subtle indicator to look at.
Yeah, that's actually a great point, and we discussed that a little bit, because we are, like you said, so used to looking and saying, it's safe to go back to the OR, but in a kid that's that healthy and he was a robust kid, you would expect it to be higher. And so that was another subtle hint that we probably missed, that something else was going on.
In the back?
What do you think happened between Friday night and Saturday morning that caused it to cascade like that?
I think he slept and was able to ignore it. I think that it was just accumulating, and he angered it when he got back in that game. And I think by the time I think we all know how it is to wake up on Saturday morning after a game or a run, and you have all this soreness that you didn't necessarily have before. And so I think he aggravated it and really started feeling it the next day. And, maybe getting out there and performing at that kind of a level in a game is what started this hematoma, or made it worse and bigger than it had been. So,
okay, why don't we talk about return to play now?
Okay.
So maybe you can share with us your approach, or are you that far into this case? Or
So, it's pretty clear for me. I tell him no, but by all accounts, I'm not this is not in my wheelhouse. But from the little bit of reading that we've done, I think it's a big risk. And I think if it were, you can talk about a little bit trying to keep the levels up with replacement, but there's not a lot of information regarding contact sports with factor VII deficiency. But I think it's a risk. I think a head bonk is a big deal. Could be a bad problem. I'm not sure that it's something that's worth going back and playing your senior year of high school football to have that kind of a problem. So, and I'm usually pretty pro sending people back to sports, but unless there's a better way to treat him than I know, I think it would be risky.
So at this point, you've recommended against him going back to contact sports in general?
Yeah, okay. I did. He's not convinced, and I'm not sure his mom's convinced either.
Yeah, they'll get a second opinion or third. Yeah.
Somebody will
they
tell
probably
them
already have.
Yeah.
Thoughts from others in the audience on this? I think this. First of all, the case is great. Thanks for sharing it. But it does raise the point, as you said, about return to sport, right? And as I always teach our fellows, sometimes to me that's the most difficult thing that we deal with. Sure. The history, the physical diagnosis, and so on. But return to play, I personally think is very difficult sometimes. And in my mind, this would be at the crux of this case. Is what do you advise, right? Yeah. Thoughts from others? Any experience with this, with factor VII? I've never seen factor VII. Maybe it's seen me, as Pierre said. I haven't seen it. I don't know. Probably has. Other thoughts from others? What you would recommend at this point? So if you recommend, so go back to sort of the Bethesda guidelines, kind of you've got your high risk, low risk sports based on intensity and contact and so on. So would you let him play basketball, for example, in the state of Kentucky? That's why I'm asking, I guess.
Yeah. And this is not based on, this is level 17 evidence, but I just think that I would keep him out of anything that would expose him to possible contact, and you can't avoid all injuries. I wouldn't tell him to stay inside all day, but I think I would encourage him to take up running or something that he wasn't going to take an elbow to the head. Mm-hmm. I think that's the safe thing to do, and it doesn't take much. I mean, this was a simple knee to his thigh, which people get all the time, and he had a huge problem from it. So I think it could have been a lot worse.
It in my mind also raises the question, was there more to the history, though? Because he's played football for a while, correct? He's played contact sports for a while. Why?
That's a great question.
And again, it's all retrospective and Monday morning quarterback. But
we
is a great place
we
to
went
talk
back
about
because there are a lot of kind of weird things with this case. But one of them is that when the HEMOC team actually got the initial labs and saw a factor VII deficiency, they said, well, that's got to be just a lab mistake, because that's
lab
so
error,
rare.
yeah.
It can't be a factor 7 deficiency in this kid. And at the time, he and his mother were not endorsing any history of any problems in the past, no history of bleeding, no family history. So they redid his workup, and it came back the same exact thing. And I remember that the last day that he was in the hospital, I was just talking to the mom, and they were already talking about when's he going to be able to play football, and I was trying to explain to him the risk, and especially if he got hit in the head. And she said, one time when he was like 12, he had this hematoma or something on his scalp, and we had a friend of ours that's a doctor that was at the house for dinner and saying that it was really an exceptional hematoma. He had never seen anything quite that bad, and it took like 3 months to go away. And we were like, well, we've been asking you this for 2 weeks now, but so that it does make me think that maybe they were, trying to dial that down a little bit, and so that he could go back and play football.
Sure. I think there was another comment back.
Regarding return to play, is Elon still following him? He's kind of managing his coagulation?
Yeah, so he sees them pretty regularly. I think right after discharge he saw him a few times. But
what are their thoughts on return to play? I'm sure he's not the first kid ever.
Right.
Might sort of want to go still play some sort of contact.
They say absolutely not. Yeah.
Just
Dr. Ireland gets the last comment.
That's right. Compartment syndrome is an emergency, and I think it's something that if you see pain out of proportion to what it should be, like these people aren't playing with their remotes or they're on their phone, they're screaming. So I think pain is one of the best of those 6 Ps, and they may not have the other ones. And like Dr. Burnham said, when you have the other ones, then it's too late. So this is something where we need to pull out the scalpel early, and maybe we do some compartment releases that maybe didn't need to be done. It might be the appendectomy that general surgeons used to do more of. So I think that's something that if you think about it, you got to get it to the right people. And the kids all want to go back, and you have to really counsel them on how. Mainly, I would be concerned about, I guess, an epidural or some kind of bad head event. Unfortunately, the peds hemonc guys are probably a lot more conservative than us sports medicine ones. So hopefully, he's out of the game.
All right, thanks very much. Yeah, great case. That's great case and great discussion. Thanks for sharing it.